Let me make it full screen. One project is going on. I will brief about this project at the end on orthopedic simulator development, device development. So later I will discuss more about this project. So as a part of this, one of my PhD students worked on database development or orthopedic simulator. It was a CT database, CT image database. So as a part of this, I'm going to talk about what modalities we have used, how we have collected data, what type of data we have collected, all those details I will discuss over here. So we are all aware about the field of computer science, and particularly the medical imaging is one of the emerging field. We can see so many people are working on medical imaging, and one important factor about the medical imaging, we are all aware that in image processing there are many fields: image processing, robotics, machine learning, all these. Some of the fields are like they are becoming saturation. Like for example, if you take document image analysis, almost came to a saturation stage. We cannot find much problems in that. Likewise, but medical imaging is such a field where there is a never-ending solutions. That means we never-ending problem. There are plenty of problems. Whatever you think, whatever the manual things are happening, we can improve it. Whatever the machine learning is being used, we can do improvement in that. So it's a never-ending field. Why? Because we know medical imaging is one of the vastly used, but still there are many opportunities. We can use the robotic technology, we can use machine learning, we can use image processing in this, and combined with the database management, that is large data sets. So it's a very emerging field, and there are no end to the opportunity in the medical imaging. So thinking that in somewhere I think 2016 or 17, I had a very long back, I had an idea. One of my friend who is working as a surgeon in medical college at Mysore Medical College, he gave me this idea somewhere around 10 years back, more than that I think, 10 to 12 years back. So that idea was there in my mind that we should develop some simulators and all. And gradually I have gone ahead and given this problem to some of my students. Actually, one student I gave in somewhere in 2013-14. That student didn't continue that work, so he discontinued PhD. Then one student joined, Darshan Ruikar. I given again this topic to him. He worked on database development, and then later we applied for a project with the DSD and for product development. So we got 65 lakhs funding for this project. Under that, 2 JRFs are working, 1 RA3 is working. And this project, I have one industry partner also, a robotic company in Pune, and now we have continued this work. So I cannot exactly disclose what work is currently going on because it's a project under execution, and we are planning to go for some patents and publications in that. But whatever the work we have done, already this work is published, so I can definitely discuss on this. So computer-based, basically this is a computer-based expert system because nowadays we are using computer everywhere for image processing and all. So it's a proactive outcome prediction system, interoperative assistance system. It's what the simulator we are developing, it is a pre-operative system. Means before going for the operation, we have to understand, like for example, let us assume somebody met with an accident, bones are broken, then the patient will be taken to hospital, and the first thing doctor will do is, they will first check which bone is broken, how it is broken, what way it is broken, they have to understand before conducting the surgery. So in the current practice, the orthopedic surgeons who are expert, They will try to understand which bone is broken, how it is broken, how many pieces have happened. Then they will conduct the surgery. Okay, they will not directly conduct the surgery. So you must have seen some of your relatives or many of us itself met with the accident. So as soon as we go, first they will do they will try to understand, okay, the entire structure, and then after some time they will go for a surgery. Immediately they will not do surgery. Why? Because understanding the structure in which the bone has broken and all is very important. If the doctor is expert, he will immediately understand exactly where he has to cut, where he has to do stitching, everything, bandage, everything, he will understand. If doctor is not expert, okay, then what happens? Properly understanding where the bone is broken will become difficult. So they are using X-ray technology for understanding the breakage and all. So even after getting X-ray, understanding the exact location is very, very important. So for that reason only, we are going to develop a simulator. Okay, we are working on a simulator which will help the doctors to exactly do the surgery. Okay, understand the problem and do the surgery. That is what we are working on. So this is a pre-operative prediction system. Before performing the operation, we have to do prediction. So doctors are currently doing manual prediction. We want to go for a computerized prediction. Okay, we want to develop a simulator which will help in doing prediction. So it is the intra-operative assisting system. So once we predict it, then it will help in doing the operation. Even a doctor who is not expert, he will be able to perfectly understand where to perform surgery, how much injury have happened, so where bones are broken, all those things will be able to, the doctor will be able to understand. So basically this uses the virtual reality. Okay, we are based skill training simulator. So what the simulators we are developing, we are using the haptic, it's a basically haptic simulator. That means, what is the meaning of haptic simulator? See, whenever somebody touches us, we will have a feeling. Okay. Suppose when we press on different objects, suppose I press on this, it is very hard. So if I press on a foam, it will be very soft. Okay. How much pressure I need to apply whenever I am doing a drilling, cutting, okay, applying suture, okay. So these are the procedures that are doctor doing whenever they want to do surgery. So that we want to bring into machine. So the machine should understand how much pressure I need to apply when I am cutting a body, when the body is a bone, when the body is a soft tissue, how much pressure I need to apply. So that we call it as a haptic. Okay, haptic. So the haptic simulator we are working on. So it uses a virtual reality skills. So here we will also take help of computer-aided detection, that is CAD tools, as well as computer-aided diagnostic tools we are going to use. So our focus is on design and development of CAD-E and CAD-X analysis and treatment, treating the complex bone structure. So before moving on to the technique what we have used in developing the database, so first thing is, whenever we want to develop any technique, we need a appropriate database. Okay, so in this I am going to only present the database what we have developed. So before going for the database section, let us understand the bone structure. So we worked on the femur bone. Femur bone means it's a bone that is both leg as well as hand bone. This long bone what we have, that is known as femur bone. Likewise we have a leg bone, so that is known as femur bone. So pre-operative outcome prediction system, so generally used by expert on a day prior to treatment, as I told you. So before going for the surgery, before 1 day, so as soon as patient meets the accident, the patient will be brought to hospital. They will first give the painkillers, okay, and then they will do all the study on the, that is X-ray. They will take X-ray, and then doctors will study where exactly they need to do proper planning. They cannot suddenly take the patient and cut the body. Okay, so and after that, usually next day early morning and all, they will do the surgery. So this helps in pre-operative surgery, and it helps in finding alternative ways to execute surgery. So whenever they conduct the surgery, they will look at different alternatives. Okay, whether to cut from one point or other point, from back side, front side, all those things. So identifying possible misinterpretations during actual surgery. Sometimes what happens when they look at the X-ray, there is a possibility of misinterpretation also. Misinterpretation means they may think that there is a crack or there is a bone, breakage of bone, but actually it may not be there. Okay, some defective information may be there in the X-ray and all. So that also our simulator will help in that. Then deciding required implants to conduct the surgery. So after conducting surgery, they will do implant also. Like for example, if the bone is totally broken, it cannot be set, then they will put the implants. Okay, that is artificial bones, limbs, all those things they will put inside and they will put these screws and so it will work like a natural body part. Then improve surgery. So our technique, whatever we are developing, that will help in improving the success rate ratio. Okay, so doctors will take our device help and they can do the surgery in a better way. So here are some bone parts are shown. Like you can see the pelvic, that is that will be in the hip. Then femur bone, so the joint of the bone with the pelvic. Then in the femur bone, that is called as the femur head. Okay, so it works like a joint. Okay, and there will be lubricant. Natural lubricant will be there in our every joint. Okay, you take any joint, hand joint, leg joint, there will be natural lubricant. Okay, so that will work like. That will help us in movement, okay, bending the leg, hand and all. So these are different parts, name of the parts. You can see here, they have done one implant. In this image, you can see this is the implant they have done. So the implant generally will be done in the aged people also. When the people become too aged, this lubricant will get damaged. So when lubricant will get damaged, whenever they move the leg, it will create a lot of pain. Okay, so when that pain is, when the persons are having pain, then also they will go for this limb replacement. That is the replacement of the femur head. Okay, so they will put the metallic femur head. So this is one interoperative assistant system. Already some work has been done by people in different parts of the world. You can see here one robotic surgical system. So in this system you can find robot is doing operations, but doctors are assisting the robots. So doctors are doing the surgery sitting at different places and robot will act. So whenever they make any movement, this robot will be working on that. This is called as interoperative assistant system. So basically, it helps in helps the expert during the surgery, and it's a mechanical task that is drilling, sewing. You can be done with the more precision. So here, doctor will be sitting and monitoring, and these are the robotic arms. And when doctor make movement, these arms are moving and it will do the surgery. So this is some kind of a remote surgery. So here robotic, the arms are assisted by the robots. Skill task trainer simulator. So basically this is what we are going to develop. We are working on the development of this skill task training simulator. So this skill task training simulator, purpose of this device is, so in the medical college what happens, when the students learn the surgery, now they are learning on the human only. So suppose if you go to any medical college hospital, you can see there are tens of people will come and see whatever is happening. Okay, that is the actual practice now. So once this simulator is developed, the trainees will be able to learn the things on the simulator, not on the actual human body. Okay, current practice is they will do trial and error. So when they do trial and error on a live person, what happens? It will be very difficult. They may do so many mistakes, and the patient will be painful. It will be very painful for the patients. And we have seen the cases where the problem is in the left leg, the doctors operated on the right leg. Okay. And they have left scissor inside the body. All these kind of things we have seen. Okay. So it is why it happens, because they are very unknown to the surgery. Okay. They do the things with carelessness. Okay, so before going for that, they need a proper training. So this simulator will help them in taking that such trainings. Okay, getting the training. So it creates a pain-free, patient-free, controlled, unhurried environment. So here, what they are doing, there is no human body first of all. Okay, they are getting the training on a usually mannequins will be there. Mannequins means fiber bodies kind of things will be there. Or it will be totally virtual reality environment. You must have seen some people wearing some goggles and doing some playing game and all. So such kind of environment will be there. So there is no live human body over there. And it's a controlled one. Controlled one means if you even try to do mistake, it will tell you are doing mistake. You have to correct yourself. So it will be giving a feedback. Okay, whenever the person is doing error, it will give a feedback. And then unhurried environment. So there is nothing like you have to complete the surgery in half an hour, 1 hour. So you can practice any long, and you can repeatedly do the practice in such environments. So repeated practice can be possible with a minimum cost. So cost is also very less because nothing is involved, only machine, everything will be there. So use virtual augmented reality, possibly with the haptic technology to provide force or tactile feedback. As I told you here, virtual reality as well as augmented reality will be used, and for that we are going to use the force feedback, what we call it as a haptic feedback. Help in teaching, training, and assessment of various orthopedic psychomotor skills and surgical procedures. So basically, our device is being developed to help the learners, okay, the surgeons who are learning the surgery, okay, how to conduct the surgery and all. So related to CAD-E, that is computer-aided detection and computer-aided diagnosis. So this CAD-E will help experts and radiologists to avoid overlooking bone injuries and can automatically analyze detected fracture bones. So there are many tools available, okay, and what we are also going to develop, basically they are helpful in understanding the structure of the bones, and also in they help us in developing a proper surgery plans. So the CAD, that is CAD-X, that is computer-aided diagnostic tools, help radiologists decide whether bone injuries are severe, help to decide suitable recovery plan process. So these are different tools that will help the surgeons in conducting as well as how to plan for the future once the surgery is being conducted. So CAD-E and CAD systems rely on computerized imaging tools and techniques. So these are all purely computer-aided tools. Okay. So and developed by the computer science engineers. So these are based on image processing, computer vision, computer graphics, virtual reality, and machine learning tools and techniques. So if you would like to really work on such tools, you need to have all these knowledges. What are those? The image processing you should know, computer vision, okay, then computer graphics, virtual reality, machine learning, and even robotics. Why? Because lot of arm movements are happening here. So what we are developing is a 3DOF, okay, degree of freedom, what we call. See, our hand moves in 3 directions. Okay, I can move in X direction, Y direction, Z direction. Okay, for that we need 3DOF, 3 degree of freedom, and my different joints will move in a different direction. See, my this joint is in this direction. I can move like this. I can move like this. 3 different directions. So when we develop this, we are developing the arm in such a way that it should also work like a hand in different directions. So the CAT for bone fracture analysis, so we use how we are going to use. If we look at why we chosen this topic, because if you see how much people are getting injuries, okay, so there is an analysis that the World Health report, that World Health Organization has reported on road traffic injuries. It says there is an increase in road traffic accidents every year. Every year the accidents are increasing, and approximately 20% of the orthopedic works occupied with the traumatic cases happen due to a road traffic accident. So among all the orthopedic problems that doctors are getting, 20% are due to accidents. Okay, for that reason, it's very essential to go for development of such tools, and basically a cost-effective tool, because you know in India we are always thinking of product which is affordable to us. Okay. So role of CADX, CAD play very important due to these factors. So CAD general steps, patient specific data collection. So what we have done to develop these tools, we have done patient specific medical images. So actually this work started when I was working in Latur University. We have taken the images. Later I will show you from where images we have collected. So images are very, very important. So two types of images, three types basically you can use: X-ray, CT scan and MRI. So we focused on the CT scan images. In fact, CT scan also uses X-ray only. Okay, we focused on CT scan images. Details about my images I will show you. Then we have done pre-processing on these images, because these images may contain some noise and all. So we eliminated the noise through pre-processing. Then we have located the region of interest. See, when you look at the CT scan image is a three-dimensional image. Okay, suppose for example, if CT scan image of my head is taken, my skull image will come. Okay, it will be a three-dimensional image. Wherever the bone part is there, that is important part. Suppose for example, let us assume a person made the accident and head injury is there. Doctor first need to identify whether there is a crack in the skull. If there is a crack in the skull, where it started, where it has ended. So they will advise the CT scan. So in the CT scan, we need to identify. That means we need to separate that bone part, and then in that bone part, where is the crack, the doctor need to identify. So for that, we call that as a region of interest localization. Exactly identifying where the problem is. Then we need to do labeling. Suppose there are multiple cracks or the bones pieces are there, we need to label them. Okay, suppose there are 4 pieces, we need to label each one, so that later when the doctor conducts surgery, they have to be put together. So I will show you this in we have done all the experiments on broken bones, and we have done all this work. I will show you later. So assign unique number to each fractured component with the consideration of bone anatomy. So the clinical aspects involved with this work is anatomy of the long bone. We need to understand how the bone look like. Okay. So without understanding the problem, we cannot develop anything. We have to understand that. So I will show you that. Then how CT scanning works, that also we need to understand, and then types of the fractures. So let us look at the anatomy of the bone. So this is the femur bone. I was talking about the femur bone and humerus bones. Okay, 2 bones that are there in the leg. So femur bone present in the lap that runs from the hip to knee. Okay, upper part of our leg, it is called as femur bone, and the lower part. So humerus present in the arm that runs from the shoulders. Okay, so this is humerus in the arm, that is the leg bone. So humerus bone is this part. Okay, from our shoulder to the middle part of the elbow. Okay, so you can see the bone structure. So again, this bone is divided into different parts. You can see both the bones are divided into different parts. So this bone is divided into 3 parts. the one part it is known as articular cartilage. Then in middle we call as epiphysis. Okay, so epiphysis, diaphysis, and then the lower part is called as distal epiphysis. Okay, so the long bone divided into two parts basically. Diaphysis, that is sharp middle part of the bone. Okay, so the middle part it is called as diaphysis, and the distal epiphysis lower end. So the lower end it is called as distal epiphysis. So bone is made up of two types of tissues. So bone contains two types of tissues. That is, upper part is a dense part which is made up of calcium, and inside that we have a bone marrow, that is soft tissue. So the dense in nature, that is it is called as cortical tissues, upper part. Okay, it is a dense. Okay, it is made up of calcium, very hard, and then provide basically this provides the strength. If we don't have that dense hard part, then we cannot stand. We have to roll and go like a snake, boneless. So because we are standing, it is because we have such bones. Then present at the outer part. So it is the outer part. And then inside that, it is called as cancellous or tabaculous tissue. Okay. So soft tissue inside that, what we call it as a bone marrow. It is like a sponge. Okay, inside the bone. And then it is helpful in injury recovering system. So whenever we get the injury, to recover from injury, this will help. Okay, fast recovery from the injury. Then present at the inner part of the bone, inside the bone is present. So now let us understand about the computer-aided tomography. It is basically developed by a person called as the Jeffrey Armstead in 1972. Okay, so then it is formed by making use of computerized X-ray measurements to produce cross-sectional tomography imaging. I think all of you are aware about the CT scan. Okay, so you must have seen everywhere you can find the CT scan and MRI. Both work on structure is same, but CT scan works on the X-ray, whereas MRI works on the magnetic waves. Okay, magnetic resonance imaging, magnetic waves. So it provides a clear insight into the scanned object without cutting. So CT scan generates the three-dimensional view. Three-dimensional view means, suppose let us assume that you have a watermelon. Okay, you know watermelon. So if you cut that into number of pieces, you can see, open and see what is there inside. Okay, if there is any damage inside, you can open and see. In the same fashion, CT scan takes the image into slices. Okay, piece by piece. So suppose, for example, there is any defect in any bone, any part of the bone, we can see in that particular slice, and we can analyze more in detail, and we can try to understand that. So but X-ray, it takes only one image. CT scan takes multiple images. That is the difference. So provides clear insight into the scanned object without getting the formation of CT scan, that is slice, depend on attenuation coefficient of scanning material. So basically, there are some settings and all. I will not go much in deep. It is not concerned to us. But we need to understand some points here. Density of the material is measured in terms of on-speed units. So it differentiates between the bone, soft tissue, okay, and the blood, all this. It will make a differentiation. And how it makes the differentiation? Based on the unit of measurement, which was named on the innovator of this CT scan, that is Hansfield, Hansfield. So it is measured in the Hansfield unit. So if you would like to know what is the Hansfield of air, it is -1000. Hansfield of water is 0, and Hansfield of bone, very hard bone, it is 1000. And so it will make differentiation. So this is the image of CT scan. So all of you must have seen this. And when the patient go inside, here is the X-ray. Okay, X-ray. There are multiple X-rays. Okay, half of this circle contains the X-ray, half contains sensors. So these X-ray, as soon as the patient goes inside, what happens? For example, let us assume this bone part is being put under X-ray, the CT scan. So first it will take one round of X-ray. Okay, and then my body will move little bit, and next it will take this one round. Okay, it will rotate. Okay, so if any one of you undergone this procedure, you can see this is rotating. It will rotate. Okay, and rotate, it will take a three-dimensional image. And after taking all these images, okay, part by part like this, suppose this much body I want to take CT scan, it will scan entire thing, and after that it will build a 3D view of this part of the body. So we call that as a CT stack. It contains basically images for every part, separate image. Okay, and we call that as a CT stack. Okay. So comprehensive collection of axial CT scan. This CT stack contains a series of CT images. Okay, X-ray images basically, and helps to preserve the depth information. So it contains the depth information also. That means at what distance the particular disease is there or crack is there, any problem is there. That depth information is also stored with the CT scan images. Then it basically creates a 3D reconstruction. It builds a three-dimensional view of the image. Then it helps in measures the X-ray beam attenuation of individual tissue. So quantitative measurement and discrimination of individual tissue is not possible. Basically, it provides the individual tissue information through X-ray imaging. So here you can see the view of the 3D stack. So let us look at individual tissue. The individual one image. Okay, how it looks. So in this picture you can see two images. One image is a normal image, and other one is with a broken bone. Okay. So intensity variation, you can see clearly there is a variation. So white part is the bone part, and the rest of the part is the soft tissue. So near diaphysis, so the image is near diaphysis, that is one end of the bone. Okay, I think both are normal images. Okay, one is near diaphysis, another one is near esophagus. So diaphysis, it was a round kind of thing. In the esophagus, there was a multiple points were there. You can see clearly the bone is appearing like that. Okay, that is first one is near diaphysis, second one is near epiphysis. Okay, so in the epiphysis, intensity value is low, thinner, and appears fuzzy. So you can see multiple components over here. Okay, now let us look at the different types of fractures. So whenever a person meet fracture, particularly these two femur bone and hand and leg bones, basically you can find that these different types of fractures. Doctor will look what type of fracture it is. So 7 types they have identified. So they are called as green stick, transverse, oblique, spiral, avulsed, segment aligned, communicated fractures. So the images are also shown. So these are all near shaft area. Near shaft area, we have 5 types of fractures. That is green stick, transverse, oblique, spiral, and segmental. And near the joint area, we have avulsed and communicated fractures. So you can see green stick means bones are not separated, a small part is damaged, okay, and then in transverse a straight cut is there, okay, straight cut in the bone. Oblique cut is there, but it is a cross sectional. Then we have spiral, cross sectional, but some part you can see here, okay, so small part is came out with the one part. So that is called as spiral. Then ours at the end, okay, at the ours is basically near the joint area. This is the joint area. So a part of the bone is broken out. Okay. Then we have segmental, multiple two. It has become 3 pieces. Okay. If bone is broken in many number of pieces, then it is called as communicated fracture. Many pieces. Okay, you can see here major accidents. You can find communicated fracture. So here this image shows a healthy bone as well as a fractured bone. In the fractured bone, you can see the bones are broken, and here 2 pieces are there. Okay, this is a separate one. This is a separate one. So in between bone and broken, and it is a CT scan slice. And near joint also, picture is not so clear, but you can differentiate between these two. Okay, so here somewhat it is more spread as compared to this. This is the normal one, and this is the broken one that is happened near the joint area. So for this, I told you we have collected data from 2 hospitals. Let us focus on now from where we have collected this data. So role of medical imaging in this is the diagnosis and prognosis. So we should be very much aware that the data is very important to do any research, particularly medical imaging, and we need to have precise data, okay, correct data. Okay, so for that we have taken help from even doctors also to do manual segmentation, collection of data as well as manual segmentation. So role of CT imaging in analyzing bone trauma severity. So why we have chosen CT images? Because CT images give us more information, better information. So that will help us in, because we want to develop the simulator which can be used for any type of surgery, any type of fractures. So for that reason, we have chosen for the CT images. So hospitals and radiology centers equipped with the large amount of the medical data. Where we get the data? We get the data in the hospitals where the orthopedic section is there, department is there, or we will be able to get from the even in the radiology centers. Okay, there are different radiology centers where there is no facility in the hospital, they will recommend to radiology center. From there also we will get it. So basically the problem is there are few problems in data collection. So we also face lot of problem during the data collection. One problem is the ethical law. There is one law called as HIPAA. Okay, what is this? Health Insurance Portability and Accountability Act. So we need to, there are many rules whenever we go for medical imaging. If you want to go for other type of imaging, there is no much problem. Okay, like document image analysis, you can scan any document and you can do it. Okay, but medical imaging, there are many rules, ethical rules. Okay, so we have to say, suppose I work on the medical imaging, I wrote a paper and submitted to any good journal. First thing they will ask whether you have taken the certification from this. If we have taken the certification from them, then only they will allow us to, then only they will take the article for further process. Otherwise, they will not process our article. That is the one big problem. So then we have patient specific data sharing protocol like IRB, Institutional Review Board. So likewise, so in every institution there will be one committee called as Review Board. So they will, whenever they give the data, they will put that our proposal to the review board, and that review board should approve it. If they don't give approval, we cannot use their data. Okay, these are some of the problems involved in the medical image. So we had to do all this when we published our articles. So from where we have collected the patient-specific CT cases from Sri Chhatrapati Shivaji Maharaj Sarvopchar Rugnalaya, that is government hospital, Chowhan, civil hospital in Solapur, And then there is one diagnostic center. This is a medical diagnostic, that is radiology center. From these two places, we have collected all our data. So we have not done our own CT scanning, okay, because we are not expert in that. We have only collected data which are already done on the actual patients, not any artificial. Okay, we didn't took anybody and say you come for the CT scanning. Actually, these scannings were conducted. From there, we have collected the data. So patient-specific cases were pulled from the archives and clinical case notes. So many patients will be coming to the hospital as well as scanning centers with the different problems. Okay. Among the different problems, we have only selected these bone images. Okay, that is hand bone as well as leg bone. So it contains so many images. Head images will be there, and other our foot images. So many images will be there. We have segregated from them. Okay, only bone images. That too quality images we have taken, and we they were patient specific, means specific to our research problem. No CT scanning protocols were prescribed. So there were, when we collected the images, we didn't prescribe any particular protocol. That means all images we have taken related to our research. So these are some technical information regarding the machines. What has been, because when we want to publish the article, we have to even give the technical information of the capturing device. Okay, so CT machine that was there in the government hospital, that is and in the radiology center. Then inclusion criteria, which images we have included in our database. CT cases inclusion criteria. CT scan from diagnostic studies included in database. So slice thickness considered less than 5 mm. See, when the radiologist conduct the CT scanning, they will keep the thickness of the image. Okay, so from moving from one point to another point, how much should be the thickness? So what we did, if we take entire CT scan, our image database will become too large. Okay, and considering one slice and next slice, there is no much difference. We cannot find much difference. So for that reason, what we did, we considered slices in such a way that we kept minimum 5 mm distance between one slice and next slice, so that we can find some level of difference between these two slices. So near the joint, so what images we have taken? The CT cases having communicated fracture. We have more focused on the communicated fracture. So communicated fracture means where bone is broken into many pieces, and then near the jointed upper and lower limb bone area preferred. So the area where we preferred is near the joint area and upper limb and lower limb area. So annotation process. So what we did, once we collected the images, anyway we are applying segmentation technique. Okay, our computer segmentation. We are developing algorithm. We have developed algorithm and we have applied our own technique. But how to compare? So when our algorithm works, it will generate a segmentation. So how to check whether my segmentation is correct or not? That is important. We have to do cross verification. Then what we did, we took the help of the doctors, expert doctors, trainee doctors, and then we got the images segmented by them. And then we cross-verified them with the expert doctors. Trainee doctors segmented it, and the expert doctors checked whether these images, whatever is being done, it is correct or not. So then after that, we compared our segmentation with them. Okay, we compared them, both of them. That I will show you in detail. So we did a manual annotation for all the images what we have collected. So it is a subjective, tedious, and extremely time-consuming task. You know, doing manual segmentation is very, very difficult. For that, we acquired some special devices, touchscreen pens we purchased, and then we got it done on the touchscreen. Okay, these manual segmentation we got it performed. Then done by resident in radiology department and tested and corrected by professors in radiology and expert orthopedic surgeons. As I told you, This manual segmentation was done by the radiology, those who conduct the CT scanning, and then they were cross-verified by the expert doctors. Detailed outcome around bone boundary. You can see the this is what the annotation. Okay, this part you can see bone part we have annotated. And then separate colors we have used for each bone part because we have to identify how many pieces are there, broken pieces. Then every 10 slice in non-fracture area and every slice in fracture bone area. So as I told you, whenever we have a non-fractured part, we do 10 slice because we want to maintain the difference between each. In the fractured slice, we took every slice for our experiment. 3D paint software and PC with the MEKO 2G high sensitivity stylus were used. So what devices we have used? We use the 3D paint software for that, and once I told you the touch screen pen, it is called as MEKO 2G high sensitivity stylus. So these devices we have used for that. So data anonymization. So this is very important. So when we collect the data, first thing what we need to do is we have to hide the patient information. That is very much mandatory. If we carry the patient information in our data, then it will be a very big problem. That patient can go to court and we will be in big trouble. Okay. So first thing what we need to do is we have to separate the patient. Whenever the CT, X-ray, MRI is conducted, they will add the data, patient information on that. That's why you can see in the X-ray, patient information will be available. So we need to separate it. Okay, in the soft copy, we have what the images we have used, they are DICOM images. So let us see how we have separated that. The DICOM header contains metadata about the study. So in the DICOM image, there is two parts. One is image part, another one is the header part. In the header part, all the patient details will be there. Patient details, what problem happened, date, time, age of the patient, male, female, all entire details will be there in the header part. So it primarily includes patient specific information, patient ID, name, sex, age, other information such as several identifiers, body part examined, image dimension, matrix size, and other acquisition parameters. So this header contains all these information. Okay. So this information is necessary to maintain relationship between CT cases and sliced images. Why this information is required? Because at any time, if patient come back, they will see, doctors will see that information. So it should match. Otherwise, what happens? They will take somebody's image and then they may go for a wrong diagnosis. So for that reason, this information is necessary. So essential for computer to display image correctly to maintain patient privacy, detaching entire DICOM header is not an option. So patient specific information is set to anonymous value. So what we did, we have only removed patient information. We have kept the other information as it is, like the image dimension, body part examined. Okay, these are not, we can keep them. First part, patient specific information such as patient ID, name, sex, age, we removed it. Remaining part we have carried. Okay, we didn't remove it. Then how much data we have collected? So this is the detail about the data what we have collected. Collected 24 patient specific CT cases. Okay, so not 24 images, it is 24 CT cases. Okay, each case will have a stack, I told you, many images that we will see. So total CT images what we have collected is 5,684 images, CT images. So fractures, so what fractures we have collected? Among 24, 8 cases from upper limb part. In that 2057 CT images, and from the lower limb 16 cases we have considered, that is 3627 CT images. Average number of slices if we calculate per patient, it is 257 images per pages. That is per patient specific CT case. And in detail, if we look at, that is, you can see here, left knee, details right knee, left shoulder, right shoulder. Likewise, if we even want to categorize the different left side and right side, these are the details. So then we have organized this database because our purpose was to collect the data and make it public. Okay. So we organize this data in a proper way, and we have now it is publicly available. Okay. So before publication, we cannot make it publicly available. But once the article got published, we have made it publicly available. But before publication, we have to organize it because the reviewers will see, we have to provide all these information, and reviewers will see this data, okay, and they will cross verify whether whatever we have claimed is correct or not. Okay, so for that reason, we have properly organized in a proper way, and this is now shared in the GitHub. So then we can see some unwanted artifact. So when we were collecting the data, we have came across some images which contain the unwanted artifacts, unwanted information. So we have removed such images. So what kind of unwanted artifacts we have faced? So we got CT bed, we got cables in between. Okay, so in the images, then we got a flesh part also. Okay, there were no bones, only flesh was visible. So such images we removed. Okay, from our image database. Then artifacts may produce difficulties in development of CAD system. So technique applied to remove artifacts. So we applied some automation technique and we removed such artifacts from the image database. Then how we removed cropped from all directions for each direction, from each direction. Then we used histogram modeling for image enhancement also. I will show you that histogram modeling. So we applied histogram sketching. It's a very simple image processing technique. Histogram basically provides the image information. So histogram of the image provides the image information. Then histogram tells about the CT image, low contrast images. Then contrast enhancement techniques also we have applied over here to improve the contrast. So some part of the code we have shown here how we have done that to improve the histogram. So these are some of the results. So that is the original CT image after applying over processing. It looks like this. You can see the unwanted background is being removed, and we have retained the black background and our bone ratio, okay, which is important for us. So these are some of the results. See, sometimes our algorithm failed here. So you can see here in the first image we have how many bones. Okay, so this is one part, and you can see each part is colored differently. This is a blue color, this is red, this is green, and here we have used some magenta kind of color. Okay, so what we did in our algorithm, we have written in such a way that each part should be colorized in a different color, so that we can easily understand how many pieces are available in the image. So here you can see only two parts. So two coloring you can find over here. Then we have compared this with the manual annotation. You can see here the one is annotated, manually annotated image, and this is automatically done through our algorithm. And then we have found out the accuracy. Okay, accuracy of our algorithm. So the different methods we have used here for the annotation. One technique is simple thresholding, which has given us 84% of accuracy. We have used active contour technique for segmentation that given us the 90% accuracy. Then region drawing we have used. These are all very old techniques. 92%. Then our own proposed method, what we have, I have just discussed so many things. that given us 95.4945% of accuracy. So this is all what we have done in our database article. So if I would like to conclude, this is what you can see. We have done flesh removal, region of interest, extraction, then labeling, and the results also I have discussed over here. So in the future, as I told you, I don't know what I have written is very old this thing. Already we have started developing the orthopedic simulator. So software component we have done quite a good work. And since this is a DST project, there was a midterm evaluation also happened from DST around 3 months back, and they were satisfied with what work we have done. Now we are working on prototype development. Okay, so within I think 3 to 4 months, we will be having a prototype working model. Okay, working model, and then we have to do work on that iteratively to improve that model, so that we want to bring a commercial product of this simulator. So at that time, these were some of the future work, but I have explained what in future we are working on. So I was talking about, we have done some publications on this. 2 articles were published in Journal of Medical Systems. It's published by Springer. It's a very high rated journal. And then we published some of the articles in the conference proceedings. So all these articles are available in the Scopus. So apart from that, as I told you, we are working on some other projects also. This is important to tell. Why? Because you should always know where what work is going on. So as I told you, this is orthopedic simulator work. It is granted in 2022. Okay. So DST BDTD, Bio Device and Technology Development. There is one section called as Biomedical Device and Technology Development. So in 2000, I applied this project. In 2022, I got sanctioned 65 lakhs, and based so 2 JAINs and 1 RA is working under this. Work is going very well. I have also another project funded by HEFA, Higher Education Financing Agency. So this has given 31 lakh for intelligent agriculture drone technology development. So we all know nowadays drones are being used in agriculture, but these drones work in a stereo fashion. Like suppose you have a paddy field and you want to spray the pesticide, so they will just move across and do the spraying. Suppose you have a mango tree, then this does not work. They will only spray from top. They uniformly spray. There is no intelligence involved in that. Only they will create a map, and they will go around and uniformly they spray the pesticide. But if you have a mango tree, how it has to spray? It has to spray all across the mango tree. Okay, every nook and corner it has to spray, and it has to do proper spraying, and it has to also look at the obstacles. Okay, so for that I applied on the project, and I got this funding. That also I got in 2022. 2 JRF, 1 JRF under this project, and 1 JRF that is UGC JRF is working under the two people are working on this. So for this also we have developed one database article. Very soon we are going to communicate that. We have conducted data collection for this very large amount of data collection. We have one agriculture drone for this, and we have one small drone, DJI small drone for data collection. We have used a small drone. We have collected data from the Hubli, Dharwad region, Dharwad-Belgaum region in that stretch. Basically, we are working on mango trees, then we will extend that to other trees later. So you can see in that region, we can find a lot of mango trees. From there we have collected, and very recently, I have gone to Dapoli. In Dapoli, Agriculture University is there, no? They have 1,000 acre land dedicated for mango trees. So from there also we have collected the data around 15 to 20 days back, 1 month back, had been to Dapoli. So there we have collected 2 days. We have collected the data. Okay. So now we are at almost finishing stage to develop a database article. We wanted the data, because of that it got delayed. So very soon we will going to submit that also. We are also working on one robotic sugarcane bud cutting machine. So on this one, not UCC. Yes, not UCC JIF. One Visheshwara PhD student, one student who is receiving fund from Visheshwara PhD scheme. She is working on that. Very recently, I got one industry partner also, who is a mechanical designer. So he's both of them. Now we all of us, we are working rigorously, and very soon, within 6 months, we will come out with a prototype. And already one initial patent was filed, so it is its validity is up to next month end, 31st May, and before that we are trying to apply for final patent for this. And industry partner is very keen to work on that. Hope we will come out with a robotic sugarcane bud cutting machine. And then I have brought 2 crore funds from the Ministry of Electronics and Information Technology under Visheshwara PhD scheme. I am nodal officer for that project in my university. So likewise, many projects are going on in the university, and if any innovative person is there, always welcome. We can do many things. In that, innovations are always welcome at my institution. If you have any questions, you can ask.
Thank you so much, sir, for your informative session. So if anyone is having any queries or questions, they can ask me.
Are there any limitations of this simulator?
Limitation, you mean?
Means the work that based on you are supposed to work on it, but not completed yet.
No.
Yes.
There are many challenges. DSP has not released last year's salary. That is one big challenge. And because of that, one JRF already left. So our work got hampered. So till now we have not received 6 months salary is not being paid. That is one big challenge. But work is going on. Industry partner is taking care of work. DST has committed that by month end they will release the salary. I mean grants. Last year grant we didn't receive, because of that we are facing a lot of challenge. Apart from that, work is going on. Mechanical design is important. We have taken the other industry partner for mechanical work, and see, industry only look for benefit. We look for publication, they look for benefit. Okay, so here when sharing comes, then we have to negotiate, discuss all that. That is the part. Even nowadays, academicians are also thinking of benefit. And see, all these ideas are my own ideas. Okay, but I have, we are working together with the other people. If I keep my idea with me only, what happens? It will die with me only. So I will be always thinking, why should I share with him? Why should I share with that fellow? I can develop on my own. So we have to also think on our constraint. I even don't get 5 minutes to do research work. Somehow I am putting a lot of efforts on my database paper. Okay. Why? Because when we go to a senior position, we will get so many responsibilities. So if you just, if I list out my responsibilities, you will become shocked. Okay, till last year I was HOD, Dean of my department. Currently I am DSW from last 3 years. I have one summer project, that is entire university automation project. And then this Visheshwara PhD scheme for entire university I have to manage. So many things are there. There is another constraint. So for that reason I have to take help from others. And then we have to, together we have to do it. If there is a difference of opinion, our project will fail. So many things are there, many challenges.
Any other query?
So the work you have done on the CT scan images, there are a number of medical imaging modalities are there. Like CT is there, MRI is there,
Yeah.
MRI is there. But is there any scope to move this work on MRI images? So far as the bones are concerned,
Yeah.
internal anatomy, bones are concerned,
The MRI basically is used for soft tissue.
soft tissue.
Cancer detection and all. MRI is used. CT is used for bones. So since our work is on bone, we have chosen the CT imaging. MRI is done, for example, inside the brain. We have brain, no?
Brain tumor detection.
Yes. There we use MRI because MRI detects soft tissues. Whereas if hard tissue, it is not much effective. Even we can use MRI for hard tissues, but CT is more effective. More effective and MRI is expensive. CT is a little bit low cost in comparison. Even if you have small question also, you can ask. Don't have to hesitate. Anybody here?
On this side.
So thank you so much, sir. Your today's session was having a lot of information about the prediction techniques and medical sector and also the data collection. So to honor you, I'd like to call Mr. Nitin Ramaya, sir, to give him the memento and certificate for his today's session. I'd like to request
Tanaji sir.
I'd like to request Mr. Tanaji, sir, to please give him memento and certificate for his today's session.
Thank you.